Welcome everyone. We're just going to wait a couple of minutes for everyone to join.
Welcome everyone to today's King's Expert Series webinar on children and young people's mental health. This webinar is part of an online event series for our global alumni community. Each month you'll have the opportunity to tune in and hear from some of our leading academics, researchers and practitioners on some of the most important issues of our time. If you missed any of our recent webinars, you can catch up at any time on King's Alumni YouTube channel. Today, you'll be hearing from our expert panel as they share their perspectives and experiences with some of the mental health challenges faced by our children and young people, especially in light of the pandemic. You'll hear about some of the challenges, but also the opportunities we have in an increasingly socially isolated yet digitally connected world. We've already shared their bios, but I'll briefly just introduce our speakers. So we have Dr. Bruce Clark, who is a senior consultant and child and adolescent psychiatrist and clinical director at South London and Maudsley NHS Foundation Trust. He's an expert in obsessive compulsive disorder and body dysmorphic disorder. Dr. Troy Chana is a consultant clinical psychologist and head of the Adolescent At-Risk and Forensic Service at the South London Maudsley. He's also head of psychology and psychotherapy for child and adolescent mental health services across the trust, and honorary lecturer in clinical psychology at the Institute of Psychiatry, Psychology and Neuroscience at King's. Dr. Trudy Seneviratne, OBE, is a consultant adult and perinatal psychiatrist and clinical director at South London Maudsley. She's lead consultant for the specialist perinatal services and a lead for children's safeguarding at the trust. Our chair for today's webinar is Dr. Ian Everall, Executive Dean of the Institute of Psychiatry, Psychology and Neuroscience at King's. Just a few quick notes about the format of the discussion before I hand over to our chair. So following introductions from our panel, we'll then turn to questions from our audience. Thank you to those who've already submitted questions in advance. If you do have a question during the webinar, please use the Q&A feature at the bottom of your screen. Do keep in mind that since we have so many of you in the audience today, we may not have time to get to every single question. You're also welcome to continue the debate on all of our topics throughout the series on LinkedIn. Just be sure to use the hashtag King's Expert Series. I'll now hand over to our chair for today's panel, Professor Ian Everall.
Thank you, Marika. Welcome, everybody. It's a pleasure to be here. I'm Ian Everall. I'm the Executive Dean of the Institute of Psychiatry, Psychology and Neuroscience here at King's College London. And we're on the same campus as the world famous Maudsley Hospital. And it's that geographical proximity that probably lies behind the reason why both the hospital and the Institute are so successful and famous. Henry Maudsley opened the Maudsley Hospital in 1923 with a vision to provide the best clinical services, excuse me, for those experiencing mental health problems, but the vision didn't stop there. He also wanted to provide the best education and the best research into mental health. And so the following year, 1924, the Maudsley Hospital Medical School was opened next door, and it was the first school to provide university level training in psychiatry and psychology, and it was recognised by the University of London. The Maudsley Hospital Medical School became the Institute of Psychiatry in 1948, and in 1997 it became a school of King's College London. Integration of the Institute into King's was completed in 2014, and it was renamed the Institute of Psychiatry, Psychology and Neuroscience, and it's now the second largest of the 9 faculties at King's, and there are over 1,300 staff, including 1,000 academics and researchers who research the breadth of mental health and neuroscience research across the lifespan, from pregnancy to old age, with lots of specialities such as addiction, such as children and young persons mental health, an MRC Brain Development Centre, and a Centre for Society and Mental Health, to name a few. The topic we are discussing this evening, children and young persons mental health, has become a health priority with a rising increase in mental health disorders in this age group, even before COVID. And importantly, 75% of all adult mental health disorders emerge before the age of 24. So if we can intervene in these early years, we can improve mental health across the lifespan. The Pears Maudsley Centre will bring together world-leading experts from the South London and Maudsley NHS Foundation Trust and King's College London's Institute of Psychiatry, Psychology and Neuroscience to identify and understand mental health problems early in life and to transform the treatment and care of children and young people in one groundbreaking, newly full integrated care and research centre, the Pears Maudsley Centre. Even before the pandemic, we knew that an estimated 1 in 8 children and young people were living with a clinically diagnosable mental health disorder, with only 1 in 4 receiving the support they needed. Now, as we recover from the pandemic, anecdotal evidence and early research suggests that the effects of the pandemic on children and young people has been mixed. In this webinar, we will discuss some of the mental health challenges we've been seeing, the ways we've adapted our clinical practices at the South London Maudsley Hospital, and in order to meet the needs and for us to be looking after the cutting edge research that the King's carries out in the hospital to improve the lives of our young people. What we want to achieve is to help young people enter adulthood with the best possible mental health. So with that introduction, I'd like to now hand over to Bruce Clark, who will introduce himself and give us a short talk. Thank you, Bruce.
Hello, thanks, Ian. It's my pleasure to meet everyone. So I'm Bruce Clark. Thanks for the introduction, Marika. So I'm the Clinical Director for Child and Adolescent Mental Health Services at the Maudsley. And just to give you a sense, we're probably, well, we are the largest child and adolescent mental health clinical and research setting in Europe. So we actually have between 500 and 600 staff, something like 550 staff. We've got around 70 consultant grade staff. I only say that just to give you a sense of it being a large service doing a lot of things right through. We provide community care across much of Southeast London. We have 4 inpatient wards as well as 22 national specialist services. So we host the majority of the highly specialist, nationally orientated services for child and adolescent mental health. Now, it's in that context that we're thinking about what our response was and what happened in the context of the COVID pandemic. So, of course, everyone's aware that in late March of this year, we faced a dramatic shift and change in what we had to do as the UK, and indeed much of the world went into lockdown. So I just thought I'd start by giving you a sense of some of the challenges that we faced. So we in fact had 4 working days to essentially close our community services to all but crisis work and have all of the staff, all 550 in our department, except the people working in crisis care and those nursing staff working on wards, all had to move to home-based care. Now that created a huge problem. We had 4 days to close 2 of our wards, because we were expecting a massive overspill of physical health patients. So we had 4 days to shut down wards. And in fact, all of the wards, child and adult wards at the Maudsley Hospital were closed in 4 days. And the pressure was so intense the NHS put us onto what was called a level 4, where we're given centralized instructions as to what to do. So we had to close all of our inpatient units. We didn't have to, but the mandate was as extreme as we may end up having people who are rendered homeless if we can't find solutions in the days for those who have housing problems. We fortunately managed it, but just the sense of the scale of which we had to ready our hospital to get physical health patients over spilling into what were previously mental health beds. So I also mentioned the fact that we had to move all of our community-based staff who were doing much of the work and much of this national specialist work to home. They couldn't come in on health and safety grounds to see people face to face. The risks were considered too high and the hospital was adapting to take physical healthcare patients. We of course then had a workforce who were at home without the required computers, without the required laptops, the sort of specialist security codes that we need and the devices that get those so that we can go into our clinical records. So the pace with which the hospital had to adapt was staggering, but initially caused a number of problems. The hospital, just as one statistic, had to provide 2,000 staff with the right sorts of laptops that would allow them to integrate successfully with our clinical records systems. And of course, that then meant that there was an onward impact to the kinds of clinical care that we saw. In fact, talking about what we've been finding out, we saw initially a massive drop-off in both referrals and people presenting in crises. So people presenting in accident and emergency with mental health crises dropped off in an unprecedented manner, the likes of which we'd never, for instance, seen over Christmases or at other times. And initially, the range of referrals dropped off. They have subsequently grown, and in many areas grown past what we were seeing before, so are back at higher levels. But working alongside our partners, both clinically and at the Institute of Psychiatry, Psychology and Neuroscience, we already were keen to start to look at, well, what are the impacts of this pandemic and the onward impact on society on young people's mental health? Now, one of my colleagues, Professor Bream, who leads a massive UK-wide genetics study looking at a lot of different things, had over 100,000 people who were signed up to that research program and had been for some time across a wide age range. And so Professor Bream very astutely went to those people and asked them to start to complete measures of how their mental health was doing in this context. And his work, alongside other pieces of research that were similar, showed what was a very interesting inverse relationship between age and the levels of mental health suffering. And so this has been replicated in multiple academic sites across the world. So in essence, the younger you are, the more likely you are to show an adverse impact of COVID-19 on your mental health and the pandemic and the aspects of isolation. Now that's over and above what we know in terms of young people's mental health. Over time, people have often worried that mental health difficulties are getting ever more prevalent across our society. Our hospital and research colleagues every 10 years carries out a massive community study across the UK. It's the largest in the world, every 10 years, looking at the rates of mental health. Now, interestingly, without going into a lot of detail, what they show is that the rates of mental health difficulty over an entire population haven't been increasing, apart from in children and young people, and very much in particular, the group of young females in this 17 to 25 age group. That is the group that has seen the largest rises in mental health difficulties even before COVID started. And I'll come back to that point. So then what are the impacts and why might we expect that we're seeing this impact, particularly in young people, of COVID with this inverse relationship. The younger you are, the more likely that you are going to screen as having signs of increased mental health burden. And what it was showing was increased mental health burden in terms of anxiety and depressed mood. Well, we don't know fully, but we're exploring things. But of course, this late adolescent period is a time of huge change. So the social determinants of health around that time include leaving home, leaving school, entering employment, entering university, all of which the brakes were put on by a pandemic, a lockdown, which took away many of those ordinary things, the sorts of social contacts that might have been ordinary experiences in that time, I think particularly adversely affect young people. The other clear fact, of course, you may not know, young people, children, young people up to 18, overall in the world, that's 28% of our population are children and young people internationally. And a fact that caught my attention was the COVID-19 pandemic closed 91% of the schools in the world. And in many parts of the world, including the United States, the schools haven't reopened since shutdown. So there are some states in the US where they have reopened, but many states where they have not reopened. And that pattern is the same around the world. Now, the schools here closed in that first wave and of course are now open, of course, and I'm sure that has a massive impact on young people. Moving on to the next area, just before I finish and hand over to my colleagues, is just thinking about some of what we've been learning. So we have shifted our staff and now offering as many appointments as we did before. We are online. We've all become very au fait with using Microsoft Teams and engaging with people in that way. But that's, of course, very different to what we did before. We're finding some really good successes working online. We are finding, for instance, that group work, people can drop in. I work in a national service myself, so people would have traveled long distances to come for our appointments. That works very well online, but many clinicians have huge and understandable anxieties about not being able to meet people face to face and engage with them face to face. It's not that we can't, we can meet people face to face, but you need to bear in mind the health and safety regulations for hospitals as such, that if we meet you face to face, we have to wear personal protective equipment. And it's not, we all know it's not very easy to see and hear and let alone pick up people's social cues if you're meeting people face to face with a face mask on. And so those are things which we have to bear in mind. Our buildings with social distancing do not allow us to see as many people face to face as we did before. So we've had to accommodate in a lot of ways. And like I say, some things have worked out really well. Some of the group work that we offer clinically perhaps works better online with people more easily joining in from different parts of families in a team meeting than they would do coming to our centre together. We're seeing particular populations of patients struggling very, very much. And so young people with autism spectrum disorders, people with eating disorders are finding lockdown very challenging. And we're also seeing a rise in the number of people coming through services with OCD. Now, that has also been found internationally. What's been very interesting from our own and other people's research, and is a positive thing, that people had worried that there would be a massive spike in suicide attempts and completed suicides, both in children, young people, and adults. And that has not been seen in anywhere where it's been studied, in Europe, in North America, in Australasia. That increase in suicides, which we'd worried about, has not been seen. Of course, if you dig into that a little bit more in detail, and experts in studying suicide note that the principal driver for pushing up rates of suicide are economic impact. And perhaps we have to be on our guard in the future for the further economic impact of the pandemic and its onward impact in mental health and potential suicide attempts or completed suicide. So something to look out for. The Office of National Statistics is predicting that there are 1.5 million young people in the UK experiencing significant mental health symptoms now that weren't before. And we have to think with other partners, how do we support that group? The services that exist simply cannot see another 1.5 million people. And so it's a broad-reaching and robust offer that we need to consider. And so on that note, I hope I've given you some food for thought, and I'm going to hand over to my colleague, Dr. Troy Tranter.
Thank you, Bruce. Welcome, Troy.
Hi there, everyone. My name is Troy Tranter. I'm Head of Psychology and Psychotherapy for CAMHS at the South London Maudsley Trust. I qualified at King's back in '94, so I've been in and around King's and the Maudsley for some time now. I also still work 1 day a week in King's on the training course for clinical psychologists. So other than heading up the psychology and psychotherapy, I also have a clinical role looking after young people in a team called the Adolescent At-Risk and Forensic Service. And that looks after young people that are presenting as a risk to themselves, predominantly through self-harm, for example. They're either presenting a risk to others or are at risk from others. And that's a lot of our work is around child sexual exploitation and the like. I thought it might be useful to give you a sort of feel for the sort of clients that we work with. They pretty much split down the middle. So half the clients would be teenage girls predominantly that are presenting with recurrent self-harm and may present many of the signs and symptoms associated with borderline personality disorder. And one young person, and the names obviously for these examples are not their real names. So one young woman, for example, is Sarah, and she's a 16-year-old white British female working with us. And when she was first referred, she was typically self-harming 3 times or more a week, violent to family, peers, and to the police. Often the police would get called to the house where she was becoming aggressive, and she would then attack the police and be taken away. She's on the edge of gangs, as a lot of the young people we see are, and is occasionally sexually exploited. A gang member, for example, will pick her up and take her across the country almost to a trap house in north of England or somewhere else on the coast. And then she just goes missing for 3 or 4 days, really, until she works out where she is and then can call the police to come and ask them to come and pick her up. So social care is involved with this young person. She's often excluded from school. Repeated admissions to inpatient units following episodes of self-harm. And with the running away, she is sometimes placed in a residential unit, but often the residential units won't take her back because of the COVID risk if she's been up and down the country. And so that then she goes to home, and then the cycle starts again of the violence towards mother and siblings, self-harm, and contact with the police. We're working with this young woman, and she's making good progress so far, but we're just trying to contain her, and it's not easy with the COVID situation. Another young person, again, not the real name, it would be Harry, 16-year-old white British young man. So Harry got referred to us because one side of our service looks after forensic cases. So these are young people that present a significant risk to others or have come into contact with the justice system, and there's an element of mental health issues related to their offending. So we work with those young people. So Harry's 16-year-old and was referred to us following episodes of inappropriate sexual behavior with a young child, a 5-year-old child. Harry was adopted. He had a horrific history of abuse from his parents and people known to the parents. Basically, Harry slept on the stairs. He didn't have a bed or a bedroom pre 5 years old when he was adopted. He presented with autism. We feel he probably had autism. It was difficult to tell because we didn't have any developmental history given his early years, and was quite obsessed with films. But we worked with him, and he's actually, this is a case that's been discharged, and he is now in a relationship with a woman and is doing very well, I think. We worked with him in a CBT type model, cognitive behavioral type model, which looked at changing his thoughts and feelings and sort of analyzing his path to that point in time, what he might want to change in the future, what his goals were, how he might achieve those, and how further offending might interfere with those. In part, that was adapted due to his autism. So that's the two types of clients we might work with, the forensic and the sort of self-harm young person. In terms of my own other interests, I'm involved in research. Got a number of research projects on the go currently. One would be merging dialectical behavior therapy, which is an intervention similar to CBT, with the performing arts. So we invite people to a theatre and we work with the young people, with artists, doing photography, spoken word, theatre work, but integrate those sessions with DBT skills. And these are all young women that are presenting with self-harm. Another study we're looking at is using a DBT app in conjunction with DBT treatment to see if the app helps in some way. And there's also a study that I'm involved in Barbados, which is working with a forensic community, a youth prison in Barbados. Challenges and positives around working during the current times. The challenges are we've experienced an increase in referrals. A lot of these young people have been forced one way or another to go home, and often the home is a point of conflict for these young people that we see. And so there's been an escalation of problems, self-harm, aggression, and the like. There's been limitations on the face-to-face work that we can do, and that's been a challenge because you know, if someone's high risk, you want to actually see them in the room sometimes. So that's made risk assessment a challenge. Positives are that it's much easier to have meetings with professionals and colleagues across the UK, for example. And we've had real success with parent groups. So we work with a lot of parents as part of our intervention, and we've had many more parents able to work with us in groups remotely online than we ever had when we asked them to come face to face because of other commitments that they had. So I think that's me. On the topic of parents, I'll hand you over to Trudy.
Brilliant. Thank you so much, Troy. That was really good to hear from both of you. So just to say, I'm Dr. Trudy Seneviratne. I'm a consultant adult and perinatal psychiatrist and a clinical director in SLAM. I work in, I work as part of a really large, fantastic, I have to say, perinatal mental health service across South London and Maudsley, where we have an inpatient 13-bedded psychiatric mother and baby unit, and we've also got an associated clinical team in each of our boroughs. So it's, as well as being a local service, it's a regional and a national service. We've also got a fantastic team of academics that we, clinical academic colleagues, working together to look at the importance of the person, so the baby from pregnancy in the early years onwards. So it really is an amazing team of clinicians and academics working with families. So thinking about the mental health of the youngest people, so babies and toddlers, I guess we have to think about the mental health of parents, and that's very much how perinatal mental health services. So traditionally, these services went from preconception, where we help parents to think about, and women particularly to think about, well, what about your illness if you have a pre-existing illness before you have a baby? And they stretch through pregnancy all the way until the baby is about 12 months old. Actually, that's going to stretch further to the child being 24 months old, because we think actually that we need to hold on to people for a little bit longer, because there's such a need to look after the mental health of the youngest. So we're looking, so in short, we're looking at a sort of whole trio, if there is a trio, so at least the mother, at least the baby, and a partner, hopefully, if there is a partner involved. And just, this is all pre-COVID stuff, but rates of illnesses we know are extremely high for this group. And bearing in mind the mental health of these women, probably about 1 in 4 women suffer from what would be described as a significant mental health problem, either in pregnancy or postnatally. And if we look at mental health rates in men, it's also very, very high. So with rates of depression antenatally and postnatally ranging from 7 to 10%, for example. So, all of this has a direct impact on the developing baby in those early years. And when we think of other factors affecting infant mental health, it's a really complicated picture, from nurture factors to nature factors, and it's important that we think about the child's development, as well as other factors that might just be interfering with their own mental health. So what happened to our services in the pandemic? As you've heard from others, there was a drastic change to the way that the services were provided. So what was a 13-bedded inpatient service for when women are very ill and there are very serious concerns about how that's impacting the baby, we suddenly had 3 or 4 dyads on the ward. That's the fewest I've ever known the unit to have in my many years of working on the unit. We've back up to about 10 beds now, but that's because we've had to change the structure of the ward to work alongside infection control. So we have fewer beds now to allow for the social distancing, to allow for infection control. So of course that means now we're back up to very high levels of demand, and the demanding capacity is not quite working. So people with very serious illnesses of depression, anxiety, affecting their babies, psychosis, don't actually have a bed to get into. We've seen similar dips in our community services and increase in rates in recent months from June and July. And thinking about how this has affected the baby, well, actually, this is affecting the baby in lots and lots of ways. So when women are going to antenatal appointments, they're pretty much having to do it on their own. And there was a period when lockdown eased when they could take partners if they had partners, but that's reverted to pretty much having to go by themselves. They were having to give birth by themselves, apart from having a midwife with them or an obstetrician with them. And this, of course, has an impact on their mood, and this then has an impact on the emotional well-being of the baby. Similarly, in the postnatal period, visits by people like midwives, health visitors have been virtual. Lots of postnatal classes and children's centre classes where parents would normally have gone to learn about infant development, child development, just to meet with other parents, simply haven't existed. So this had a net result of parents, and particularly new parents with babies and single parents, being in an isolated state, and that's had really, we're getting lots of anecdotal information, but some of the earlier surveys that we've been doing nationally are starting to show that actually parents' mental health with young babies and young children is being affected. I'll come on to some positives of what we're learning later. So just a couple of examples then of people that have been through our perinatal mental health services and our mother and baby units and our community services. What we're seeing is, our parents very concerned about the well-being of their baby. So the women that have come onto the mother and baby unit have, for example, have really quite, perhaps even more severe levels of depression, anxiety, suicidality, obsessive compulsive disorders or psychosis, because they've left it too long and have only sort of come onto the ward when they've become very, very severe. So actually we've had a really high acuity in the women that have been admitted and started to come onto the ward from June and July onwards. That's very, very different. And although women never want this to impact on the emotional world of the baby, actually we've had to do quite a lot to support them in that relationship with the baby. That's been really difficult because using PPE, staff have had to wear masks, and actually how do you interact with a baby and teach parents or mothers how to interact with a baby when actually we're all wandering around the ward with masks on our face. And so that's been a real concern actually on an inpatient setting, trying to work with not just the mother and the parent, but actually for the babies themselves, being around staff who are all wearing masks the whole time. So we've tried to mitigate that as much as possible by making sure babies are outside and go outside, and that they get to see real faces, not just a half a face. And we're looking at having perspex visors to have on the wards, but we haven't quite got there yet. So a bit like producing the vaccine, we're trying to get the perfect visors that we can have for this. Lots of complications around. We've had plenty of mums who've had COVID, and also babies who've had COVID, and of course that then has affected their emotional and social and cognitive well-being as well. But the good thing is that these cases, when they do come to a ward, even though they're pretty serious and we're concerned about both the mother and the baby and the parent and the partner, they do receive really good holistic multidisciplinary care. Now, despite the fact that some staff had to work from home because of needing to isolate, we've tried to deliver as many of our rich psychological and social treatments, and occupational therapy, for example. We've tried to somehow be able to deliver that, and all the biological treatments that have absolutely continued as well. So just finally, just mindful of time, what are the positives from some of this? Well, some of the positives are actually, as you've heard from the others, the virtual working is not a bad thing. Actually, it's proving to be a really good thing for families, parents, babies and families who come from quite a long way away, given this is a national service. So it means that families have been able to join for virtual reviews, professionals have been able to join for virtual reviews. Ideally, many of the non-pharmacological therapies, so the psychological therapies, we use lots of video work with parents and babies. We use things like infant massage, and actually those are generally much better delivered in a face-to-face setting. However, we have learned to adapt these to delivering them virtually. So for families at home, teaching and doing that on a virtual platform and encouraging people to do this at home. Of course, that requires families to have proper IT at home to be able to do that. And the other good thing around globally around the development of babies is that for some families, it's probably been a really good thing that parents have been at home, that parents somehow have been given permission to be at home for quite a significant chunk of time rather than being at work. So where perhaps normally both parents might have gone to work and left the baby or the young child at home in a nursery, for some people actually I think it's been a positive that parents have been able to be at home and be with their babies, because if those parents are the primary caregivers for that baby. So there are some good things. There are negative things, of course, if there are issues of things like domestic violence or parents drinking more alcohol around their babies and toddlers. But actually, there's a big part of it that is also very positive. My final word I'm going to say is that I don't know if you saw in the papers yesterday, but there was an announcement from the Treasury and Rishi Sunak yesterday that there's going to be an additional £500 million for mental health. Now, you know, it's a step. Perhaps, you know, some people might think it's a big step, but actually it's not a huge step. It's a step in the right direction of giving more money for mental health, because the government are acknowledging that there is an impact on mental health for people. And actually quite a big chunk of that 50 million is going towards children's mental health services and children's mental health, and across both services and schools and environments where children's mental health can be looked after. So that will be across all children, not just babies, but I think that can only be a good thing. So I'm going to stop there, because I think between us we've probably gone way overboard, and I'm going to hand back to Ian at this point. Thank you, Ian.
Thank you very much, Trudy. Thank you for wonderful presentations from you and Troy and Bruce. We're going to now move into our question and answer discussions session. I'd just like to start off, Chair's prerogative, of asking you a question myself. I think we're all really, really excited about the groundbreaking new Pears Maudsley Centre for Children and Young Person, which will soon be built at Denmark Hill on the campus between the hospital and the institute. Can I ask you each to tell me a bit about the centre and what it will mean for you work in your area? And if we go in the same order, we'll go Bruce, then Troy, then Trudy.
Okay, I'll go first. There's so many things, it's hard to be brief, but I have to be. So for me, it's about taking things to scale, you know, the scale of the issue of mental health difficulties that were unmet in our society was massive even before impacts like COVID. And so really, we need to use this in essence, what we're doing is putting all of the researchers who work in this field alongside all of the specialist mental health clinicians working with children and young people. And that synergy will rapidly translate some of the new findings into clinical practice. And we absolutely have to do that so that there can be a step change internationally in where we're going with the assessment and innovative treatment of children and young people. There's so many exciting things which we don't have time to go into detail, but some of the digital platforms that we'll be able to develop, which will take things to a different scale. You know, 1.5 million, how do you deliver things? Well, digital is going to be a really important part of mental health treatments. And this opportunity and all of the funding that goes behind that to bring research and clinical practice forward is going to be really, really groundbreaking.
Thanks, Bruce. Now, could I ask Troy to give us his views, and then Trudy? Thank you.
Thank you. For my mind, it's the opportunity for collaboration, really, that's quite exciting. As you said earlier, the two institutions, King's Institute of Psychiatry, Psychology and Neuroscience, are on the same site, but having us under the same roof, I think will increase the likelihood of collaboration. And for people like myself to have a clinical challenge that I'm facing and be able to discuss it with academic colleagues and sort of say, you know, this is the conundrum, we're working with complex trauma. Do you see some way around that we could collaborate on? As Bruce just mentioned, digital developments. I'm part of a group in CAMS that are working on moving forward with our digital developments. And that's using digital expertise and strategies to address outcome measures, assessments, treatments. And that sounds very exciting in terms of using...
Troy, do you just want to explain what CAMS is?
Oh, sorry, yeah. Child and Adolescent Mental Health Services. Apologies.
Thank you.
So working with colleagues to sort of, you know, I'm currently having discussions with one of my IOP PPN colleagues around the use of virtual reality in treating young people with aggression, issues around aggression. So how can we do that? And I see those collaborations increasing markedly with the new building.
Thanks, Troy. Trudy?
Yeah, thanks, Ian. That's exactly what I'm hoping for, I think, just adding on to that. I think it will provide a really wonderful opportunity for collaboration between the clinicians and scientists. And, you know, people's mental health starts right at the beginning, and we haven't got a place where we can, you know, although we're doing lots of brilliant clinical academic work, actually to have a space and an area to bring people together where we can, you know, think about infant mental health, early years mental health, you know, new treatments, new family work, thinking family. That would be really amazing. So I'm looking forward to that.
Thanks, Trudy. I think the other thing we strongly believe in is that by putting the clinicians together with the research and academics, we can hopefully shorten that big lag from discovery to being used in the clinic from about 18 years down to about 7 or 8. So we're really hoping to speed up discovery and speed up how we can improve the quality of life of young people, children and young people with mental health problems. I just want to now turn to some of the questions which are beginning to come in from the audience. And David Verrick says, does the panel envisage continuing with online sessions even when the restrictions on face-to-face are lifted? Who would like to answer that?
Happy to.
Thanks, Troy.
Certainly, we've had some good experience in working with parents and with other professionals. So I think the online work with those groups will certainly continue. I was chatting with Bruce earlier, in fact, about the use of the online assessment and treatment with young people. And I think there is a place, because we're all involved in national services, which involve an awful lot of travel for a lot of these young people and families, which often, you know, is inconvenient, of course, but also means the missing school, which isn't ideal. So if we can meet the young people and family face to face, but then do much of the treatment online and just touch base every now and then face to face, I can see that as a model that would work effectively.
I would just add, Troy, the simple fact that before COVID-19, our building and plans for Pairs Maudsley Centre have been long in the making. We always had a plan for 20-25% of our appointments in the future to be using virtual. And so we had actually been developing the ways we do virtual work. And I've been doing some research in my own clinical team, the National Specialist Service for OCD and Body Dysmorphia. And actually the feedback from families is very positive about having online assessments and treatments. So it is always going to be part of our lives, I think. We never anticipated that we'd get so used to using it so quickly, but it will be part of work going forward.
I think you're right, Bruce. I mean, you know, with the pandemic, we've had to adopt technology, which would have, under normal circumstances, taken 5 to 10 years. So we've been pushed into using technology, and thank goodness we have it. So Dr. Chakrabarti says, how much of the current epidemic in child and adolescent mental health is due to insomnia, from youngsters staying up late, playing with all their gadgets, and a related inability to cope with the consequent information overload? Which of the three would like to start off with that?
I don't mind, I'll have a go. Actually, Dr. Chakrabarti, I feel very passionately about lack of sleep in young people. And there's lots of evidence, actually, that young sleep has a really potent impact on children and young people. So staying up with your phone is actually a really negative impact. And it might be one of the biggest ways, in fact, that mental health can be adversely affected by online platforms. Parents often worry enormously about the amounts of time that their kids use their phones for in everyday life. And if you leave aside staying up all night and getting exhausted, which has an onward impact on your mental health, there's quite a lot of research to show that in most circumstances, simply using the internet for a huge amount of time isn't as bad a negative an impact on mental health as we might have worried. So there's actually quite a lot of research drawing together around that. There are obviously areas that are of concern. So if I think about the patient population that I work with body dysmorphia, there is a particularly pernicious aspect of online life, comparing oneself to different stars and posting lots and lots of selfies and so forth can get into a very destructive pattern. Likewise, eating disorders, people getting advice about about how to diet in the extreme and comparing themselves and so forth. But that always has to be tempered with the internet brings enormous positives. The fact that young people can keep in touch in much the same way as they did before the pandemic, that people, the first place anyone goes now when they're worried about their health is the internet. So the internet as such has facets that are difficult, positives and negatives, but insomnia from using it too much, definitely worry about that, and good limits on access and wind down, good sleep hygiene. If people are interested, Sleep Scotland have done a lot nationally in inculcating good sleep patterns across Scotland with really positive impacts. And they've got lots of stuff online if you want to Google Sleep Scotland to think about advice around healthy sleep for kids and sleep hygiene. So that's how I would answer that.
Thanks, Bruce. Along a similar line, Georgina Lupo-Florian says, do you recommend any mobile apps focused on mental health for children, young people? Do you think there are certain diagnoses or intervention techniques or tools that can be digitalized? If so, what are those? Trudy or Troy, do you want to start off, and then we'll possibly come back to Bruce?
I'm doing some research at the moment, which is using an app, which is DBT Coach. So we're very interested to see whether the use of this app as an adjunct to normal DBT has advantages in the sort of use of DBT skills in these young people. DBT, sorry, is dialectical behavior therapy. So I think there's a lot of us exploring the potential uses of apps in mental health.
Have you got any results yet? Have you found out it is more effective? Troy, sorry.
It's ongoing research, sorry.
Okay, great. Bruce, sorry.
So we did some, it's not per se an app, you don't tap a single app on your phone, but it's an internet-based treatment protocol for OCD. We did it jointly with the Karolinska Institute. So treating people with mild to moderate OCD, showing really good outcomes equivalent to face-to-face clinical practice. And that research wasn't solely online. It involved some contact with a psychologist, but a third of the hours of face-to-face activity that you would have had if you were in treatment as usual. And it showed just as positive outcomes in that mild to moderate group. And so we're extending that to look at how far you can take it as just an internet-based program. We're also extending it to other areas. There's a lot of app development in what we call affective disorders, so thinking about mood-based treatments, trauma-based treatments, and anxiety-based treatments online. Some really positive data locally and internationally. So it's really, really an important space. And actually, that, as I mentioned earlier, that digital piece is our largest tranche of research built into our new ideas to really capitalize understanding how we integrate digital into all sorts of different aspects of assessment, monitoring. You can use digital space to monitor treatment response, how active people are, etc., etc. So lots and lots to be done there.
Thanks, Bruce. Trudy, did you have anything you wanted to add?
Yeah, I mean, there is plenty of work happening. I mean, a really good project actually that we fed into was for an app called the Baby Buddy app, which is by charity Best Beginnings, but it was a whole group of people that helped with this Baby Buddy app, and it's absolutely fantastic. It has an avatar where women and partners can log on, and so as a woman you log on and you can track your pregnancy and the development of your baby, but also for the woman. And it's been, there's been a high uptake of young parents, for example, as well as sort of older parents. It tracks the development of the pregnancy, of the fetus, and then subsequently it sort of helps parents understand how the baby is developing in terms not just of the physical development, but also around the emotional and social and cognitive development. It's got some videos of interactions with babies and learning about the emotional and social cognitive development of the baby. It's a really, really lovely app, and would love that to be rolled out and used right across the country. So it's been used a lot. I mean, it's been 10 years in the making. It's sort of been it takes a long time to develop these things, doesn't it? But we're hoping, you talked about a pipeline, that this will speed up and be disseminated really quickly now.
A lot of exciting things happening. So we've got a question from Bob Foster. I think it's probably for you, Bruce. Can you describe the interventions you use with young people, especially those with OCD, obsessive compulsive disorder, and how you've implemented these treatments approaches during COVID?
That's definitely one for me. So the evidence base is clear and really strong. I like working with OCD because I would say it's about the most treatable mental health disorder. There's no complex cases, it's there for the taking. I feel very positive about treating people with OCD. There are two main evidence-based treatments. The simple one to mention is there are medications that are used in some people that can be helpful, but the bedrock and the treatment with the largest effect, the most powerful effect, is a particular type of cognitive behavioral therapy, and the backbone of that is called exposure and response prevention. It's it's a well understood treatment. We've just literally published 2 sets of treatment manuals, one for children and young people with OCD, if you like, OCD on its own. There's a treatment manual for therapists and a workbook for young people. We've got a matching parallel set for people who are on the autism spectrum with OCD. So those 4 books have come out, and it tells you and walks you through how to deliver those treatment programs. So a standard treatment protocol of CBT for a child or young person with OCD would be 14 weekly face-to-face sessions. Now, face-to-face, we still call it face-to-face work when we're working online and through online media, and it seems to be working quite well. We will be drawing together the data because we measure accurately the outputs and the outcomes. It's seeming good, and we will publish papers as to what's happened in the pandemic where we've worked online. We have some concerns about that because ordinarily best practice would say that you need to do active work in the room live together, doing some of those exposure tasks, and we do them live together but online, and we do need to watch the impact of that and see where we get some strengths and difficulties. The difficulties is we're not together, we can't really push in the same way, but the positives are sometimes that you're exposing a person in the home environment where their OCD is at their most acute. So we are actively, we're offering the same number of appointments as we did before, and we're actually seeing good outcomes. It doesn't feel that different. We've done research trials in the past with telephone CBT showing just as good outcomes, and I think video might take that to a different level. So yeah, it's a really good disorder to treat. People get better.
Thanks, Bruce. That's really helpful. We've only got less than 5 minutes left. So there is a question that's come in, and maybe this could possibly be for Troy or Trudy. Will the new centre support local CAMHS teams around the UK in any way? I've known some people can struggle to get taken on by CAMHS in the first place, and that they may not always be equipped to deal with complex disorders.
I think a large part, I mean, as we've said, the collaboration between clinicians and academics will increase the knowledge within the centre, and that will, a main aim of that gathering of knowledge is to share that nationally, internationally, with colleagues across CAMHS across the UK. I'd argue that King's and SLAM is already highly respected mental health resource, but we can aim to do better, I think.
I completely agree with you. Trudy, what do you think?
Yeah, no, I think I guess we can only do more. I mean, what I'd like to see more of is a focus on the early years work. I think, you know, when we think of CAMHS, I think we traditionally think of, you know, the child and starting from about 4 or 5 when it comes from, you know, the psychiatric side, if I can put it that way. But actually, you know, the child develops from pregnancy onwards, and I'd really love us to focus on the sort of early years mental health and early years clinical academic partnership, you know, a lot more. That would be really fantastic, and then we can then hopefully be a beacon to sort of other early years services around the country. I think there is no good model of early years services at the moment, or there are different models of how that can be delivered, and I think that needs a lot more integrating.
Thanks, Trudy. Bruce, some of you run national service. What about supporting CAMHS teams up and down the country?
Yeah, as Troy said, well, I'll just add one wee thing to that. So we definitely have lots of perinatal research going on. So that is going to be an exciting development. So more of that, I couldn't agree more. Yep, we do. So my team already run frequent national training programs. We ran, I think, somewhere close to 30 one-day trainings around the UK for people working with OCD and CBT. We now do those online, actually, which allows people to join more readily. And the new centre is going to have an educational charter so that all the researchers and all of the clinicians coming in have to really expand. So we're putting investment into wider expansion of the educational outputs of the service and centre. So yeah, we do it already. I think we have a good reputation for doing that, and we want to do ever more. What we'd actually really like to do is have that inward investment that would allow us to not just offer a training, but then offer with that capacity to deliver more ongoing supervision for people who are actually picking up the skills and maybe need a bit more of a helping hand along the way.
Thanks, Bruce. Thanks, Troy, and thanks, Trudy. It's amazing how quickly an hour can go. We've now exceeded our time. It's now 6 o'clock. We basically just scratch the surface of a really complex problem that's really important as a priority for societal needs in looking after young people and children with mental health, so that they have the best opportunity of entering adulthood with good mental health as well. And I think that the three of you do fantastic work, and it'll be great when we combine the work even more with new clinicians and the academics being in one building and working even more closely together. I want to apologise to the people who've submitted questions that we've not had the time to ask, but I hope that we will have an opportunity to repeat a similar kind of session at some point in the future. And I'd like to thank the KCL Alumni Office for supporting us in this. Marika, shall I hand back to you?
Yes, thank you very much, Ian. Thank you to all our lovely speakers for such an insightful conversation today. And thank you to our audience for your participation and thoughtful questions. Before I close the session today, just a couple of reminders. As you've heard today, children and young people's mental health is a strategic priority for King's and our health partners. If you would like to find out more about our work, please be sure to let us know in the post-event survey so we can keep you updated. Next up in the King's Expert series, we'll be discussing the future of our cities and the economy. Look out for your invites to those in the new year. We do have some exciting activities planned for December as well. So do take a look at the website for those. And finally, we're really pleased to be launching the latest issue of our digital alumni magazine, In Touch, coming out next week. So do keep an eye on your inboxes for that. Thank you again, and goodbye for now.
Thank you. Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thanks.